going to talk to you about a technique for crossing and treating totally occluded aortoiliac segments. Here are my disclosures. So the background, I'm going to propose that based on operator experience, endovascular-only approaches for treating aortoiliac occlusions can be considered first over hybrid approaches or open repair for even the most complex cases. Open surgical procedures result in longer hospital stays and a significant mortality and morbidity rate. With technical and procedural advances, endovascular approaches result in reduced hospital stay and cost in addition to reduced major complications with comparable patency. When you look at the TASC lesion classification, you start with type A, which is the least complex, to type D, which is the most complex. Traditionally, endovascular approaches were relegated to type A and B, with C and D being surgical approaches. But today, with current advances, type D lesions can actually be approached endovascularly. But I do caution that when symptoms are abrupt, think of thrombotic disease, and your treatment management strategy may change. And also be cautious with severe calcification, excessive tortuosity, and be cognizant of the adjacent branch vessels. So here are the steps for a successful endovascular intervention for aortoiliac occlusions. Step 1, understand the anatomy. A pre-procedural imaging is very crucial to help develop an interventional strategy. At our institution, we perform CTAs, but you can also do an MRA. And if you have neither available, you can do a diagnostic angiogram. And what you want to identify are lesion lengths, calcification, the plaque burden, vessel diameter, vessel tortuosity, and the inflow and outflow access. So angiography oftentimes fails to identify a reconstitution zone. If you look at the left common femoral artery on this angiogram, you see an aortic occlusion, but no reconstitution in the common femoral on the left side. You've seen this picture by Dr. Walker showing the pathway of Winslow collateral, filling in the left common femoral artery. And by shooting the IMA, you can actually see this, and now you have a target for access. Step 2. Get access. And I advocate for ultrasound-guided access as well as micropuncture access to mitigate untoward events. For focal infrarenal aortic occlusions, we typically use a single femoral artery access site as well as a brachial radial access site to help visualize from above and to facilitate crossing. For bilateral common iliac or aortoiliac bifurcation occlusions, we use bilateral common femoral artery access as well as a brachial access. You want to do an angiogram after you you get access to ensure that you have a non-occlusive sheath. You want to be able to size your sheath appropriately to avoid complications. The same goes for the femoral access sites prior to placing your sheaths. Step 3, get the equipment ready. So the catheters we utilize are typically 4 or 5 French support catheters that are either straight or angled. We have a wide variety of wires that we can choose from. We usually use a wire escalation approach. You can attempt a finesse approach of wiring the true lumen, but be prepared to switch to a wire loop technique. Typically, what I start with is an 18 thousandths wire, followed by escalating to a 0.35-inch stiff angled hydrophilic glide wire. Have an aortic occlusive balloon on your shelf as a bailout in the case of catastrophe. And also make sure you have a good inventory of covered and self-expanding stents and know what sizes you have ahead of time so that you're not scrambling after crossing. Step 4, cross the occlusion. So you place an angled or straight crossing catheter with an angled stiff glide wire at the occlusion site. You probe the proximal cap by spinning your wire and then prolapse and push the wire using the support of the crossing catheter until you re-enter the true lumen. You remove the wire and aspirate for blood and perform a general contrast injection to confirm intraluminal position. Then next you want to externalize your wire through the femoral sheath for added rail support and to assist delivery of the balloons. You've reversed the wires at this point by advancing the crossing catheter in a retrograde fashion so that you can free up your brachial sheath for contralateral iliac crossing. And if the catheters don't cross easily, dilate the tract gently first. Dilation of this tract is important, and you use smaller balloons, usually 5 to 6 millimeters. And I sometimes use this balloon as an assistance to cross the contralateral iliac, as it keeps me in the same plane of the occluded iliac. So crossing this contralateral iliac is done in a similar fashion. You direct the wire to the other iliac, the lowest point before the bifurcation. We use angled catheters with a straight tip glide wire to help penetrate the cap, followed by prolapsing the wire with an angled stiff glide wire. You repeat the steps: confirm re-entry, externalize the wire, reverse the wire, and dilate the tract. So here are some tips. In our experience, crossing from above has yielded our highest success. If one approach doesn't work, be prepared to change to another. Use your fluoroscopic details. Dissection planes with small wires are more forgiving than with larger wire systems. And when false channels develop, don't fret. Pull your catheter and wire back proximally and redirect. Step 5, prepare to stent. So use a contrast injection to help define a stent strategy. Roadmaps, anatomical landmarks, radiopaque rulers can be helpful in this regard. You want to utilize IVUS and, if necessary, dilate with larger balloons. Identify a stent strategy. For us, if you see an occlusion of the aorta at the IMA level or above, we use a single aortic stent followed by kissing covered aortoiliac stents and self-expanding external iliac stents. If the occlusion is below the IMA, use a kissing aortoiliac stent that are covered, as well as external iliac self-expanding stents. And special considerations to keep in mind are lesions at the level of the renal arteries. You want to protect your renal arteries, and also you want to try to avoid using covered stents over a patent IMA. So step 6, stent. Ensure that both tracks to the aorta have been adequately pre-dilated. The next thing you want to do is decide which iliac was easier to cross. Advance your aortic stent on the other side. And then what you want to do is pull your trapped wire and then recross through the stents. You post-dilate the stent with kissing balloon inflations. The next step is to place your covered aortoiliac stents by placing your femoral sheaths into the aorta. Deploy your stents simultaneously, and remember to preserve your internal iliacs and try not to occlude your IMA. Then you place your external iliac stents, self-expanding typically. Pre-dilate the iliacs conservatively to avoid rupture. Step 7 is to perform your final angiogram to evaluate for any untoward complications and consider a final IVUS run. Step 8, probably one of the most important steps, is adequate access closure. You want to try to avoid intraluminal closure devices if at all possible. Check your ACTs. Ensure there's flow around the sheath, and if necessary, you see an occlusive sheath, try to get it out as soon as possible. This may require protamine or sometimes a balloon occlusion for hemostasis. Calcium is very, very dangerous in these situations. You want to use the physics of POBA when dilating these lesions. Low, slow inflations, longer inflations to dilate the lesions. Sometimes calcium can be unforgiving and lead to bleeding complications and very hard to stop. In this case, it was an access site bleed that required covered stenting to treat. So here are a few cases. A 57-year-old male with Rutherford III claudication. He had a distal aortic occlusion at the level of the IMA. We did a single aortic stent strategy followed by kissing covered aortoiliac stents and external iliac stents with a good angiographic result. Here's another interesting case of a 72-year-old gentleman who had a solitary kidney with a renal artery stenosis at that site, as well as a distal aortic occlusion at that level. Here's the angiogram. You see the SMA and celiac filling, and on the picture on the right, you see the stenosis and occlusion of the renal artery and aorta. So in this case, you protect the renal artery, placed a balloon and wire in the renal artery, deployed the aortic stent, then followed this with a covered renal artery stent. We did kissing balloon inflations, and were able to achieve a good result. These can last a long time. This is a case I did last week on a patient who had aortoiliac stenting 28 years ago, and just in the last year started to develop pain in the right leg. He had an occluded limb on the right side. This was treated with laser atherectomy, followed by a covered stent in the aortoiliac segment with a good angiographic result. So in summary, TASC C and D aortoiliac lesions can be effectively approached by traditional endovascular techniques with excellent patency, reduced costs, and lower morbidity and mortality compared to open surgical approaches. And to have the highest chance of success and avoid complications, gain expertise, start with the lowest risk cases first, plan the procedure, and pay meticulous attention to the details. Thank you.